So jump right into David Hardin's talk on refractive options in patients with suspicious corneas.
All right, well, good morning. I want to thank the organizers for a fantastic meeting and the Academy for the opportunity to present this. I have my financial interests are listed up there, but none that probably specifically pertain to this specific talk. So I'm charged with trying to say if something is suspicious, then you know, how do we manage that? And so I decided when I step back from this, I think, okay, well, what's suspicious, and which is convinced that we know that it's guilty, I guess. So you've got the suspicion of a crime, and then you've got the process of deciding it, and then you like put somebody in jail, right? So the things that we're looking for when we try to take a cornea that we think is suspicious and try to decide, are we going to reshape it with corneal refractive surgery, or are we going to do something else, glasses, contacts, keratoplasty, that type of thing. You have to figure out, well, what are the disease processes that we think of? So you've got keratoconus, obviously, and keratoconus in most patients, especially the younger patients, that's not a stable situation. It's suspicious, and then we have to decide based upon be different in a year or two years or 5 years, and obviously it's hard to create a 20-year plan as we've talked about in that last session, and you know, because eventually the lens is the answer for most of these patients. Basement membrane dystrophy, so that happens all on top of the structural aspect of it, or the corneal stroma that you'd be reshaping. So that one to me is a pretty reasonable one to do something with on a therapeutic basis. Corneal scars, again, most of those are relatively stable over time, and then there's other miscellaneous diseases. And so we need to know, is it stable? Do we know is it stable? Do we think it's going to be stable? Is it really unknown? So you want to make sure it's not that tire in the middle, right? So can you imagine deciding, oh, I don't like that bump on my tire, I'm going to go shave that bump off, you know, in the morning before your entry on the posterior side, so there's some scar and fibrosis, and they've got basement membrane dystrophy. And this was a while back, and so we think that it's probably going to be stable. So in this situation, basically, we're able to capture a wavefront based system with higher resolution than we've had in the past. I tried it on 2 different machines that I have and was able to capture it on the higher resolution machine, and this patient did quite well with corneal refractive surgery because it's suspicious if you think of just the topography, but it's stable. It's likely to be stable in the future, and this patient did quite well with that treatment. So basically, you know, it's really therapeutic because it's an uneven cornea. So I called it PTK as opposed to PRK because it's not just a straight refractive error. And the patient had quality of vision issues, and he's very happy now with the quality. So what about the keratoconus eyes? And you know, this is a little bit controversial, but we now have cross-linking, and we have intacs, we have other things that we do that we think probably stabilize a cornea that would otherwise be suspicious of progressing into the future, and maybe we're going to create a stable situation out of a potentially unstable situation. Where is that stable or unstable? It probably was unstable until we stabilized it with another procedure. And so, you know, basically here's just my typical approach where I'll use conductive keratoplasty over the apex of the cone right slightly outside of the channel, and then channel with the intacs with a femtosecond laser, and then add the intrastromal rings in there. And I've started actually with because I'll oftentimes use asymmetric segments, I've had a couple that overlap, and so I've actually started to put a suture not only in the incision but also on the opposite side, in between the segments that I leave in for 6 to 8 weeks, so that hopefully they don't slide over it. So the ocular optics are very complex in a lot of these eyes, and so topography or wavefront guided treatments are important. And in the handout, I've kind of listed the advantage of a topography system is that you can do this if you are concerned about intraocular aberration. So for example, if you've got somebody that's got a really irregular cornea, but they've also got some lens abnormalities, they've got cataract, et cetera, wavefront guided treatments are not really practical, whereas the topography guided treatments are more practical for that. And again, with some of the newer, higher resolution aberrometry, you can image very complicated corneas and get very good results with that. So in summary, you have to figure out, well, why are you suspicious? Is it keratoconus that may progress? Is it some other disease entity that's likely to progress? Or is it something that is thought to be stable? In your best judgment, you think it's stable. Scar, basement membrane dystrophy, the other type of superficial dystrophies. And it's also that aspect of counseling and expectation setting. So you make sure you do your diagnostic work, like we'll hear about in some of these other talks, but many of these treatments are very good for patients without resorting to keratoplasty. Thank you.
Great. That was terrific, Dave. You know, it kind of made me think we're really lucky that we have all the great tools and all the great options for these patients. And I like the way you emphasize that in these younger patients, they may not be stable. And so we really have to be a bit more careful in the younger patients. I was wondering, you know, how long do you wait after you do cross-linking before you go on to do maybe a PRK procedure?
You know, I've been waiting, it's a good question. I've been waiting 6 months to a year based upon some of the anecdotal cases that I've seen presented where if they're treated a month later, for example, that they have more haze or scar tissue formation. I think the answer is still to be determined, and that, you know, when's the right time. And I typically don't do it at the same time in these more, you know, kind of moderate cases because of the fact that I'm concerned that there's going to be some shape change, although there's certainly some groups that are doing it at the same time as cross-linking and getting reasonable results in some of the patients with more severe disease. So.
And one other quick question for you. For someone just getting started, what imaging would you say is essential that you would recommend in these refractive patients? Like, what would be the baseline imaging that you would recommend?
I'm going to let Renato talk about that.
Okay.
So because he's going to share that in a whole 7 minutes. But
Okay.
so I think that imaging the posterior surface is really critical. I guess I'll just say that.
Okay.
And the anterior reflection surface, I think, is very helpful for the cataract age patient because of the fact that it is, I think, more sensitive to picking up things like basement membrane dystrophy, subtle old foreign body scars, to make you go back and look a second time at the cornea in that group of patients. So.
Perfect. Thank you.